Because here's the one I'm going to tell you. I have these two talks, 30 minutes. I may give one today, and then we can give it the other 30 minutes in the future then.
Great. All right. Ladies and gentlemen, welcome back to our international ground rounds. Very pleased to have a superstar today. We are going to have a deep dive on the endonasal approaches and anatomy of the skull base. I have the pleasure to have a guest, Daniel Prevedello, MD from the Ohio State University. Good morning.
Good morning. Good morning. For me, it's starting afternoon now here, like just past noon. Thank you for having me. It's really an honor.
Discussion, me and with Daniel Prevedello. I've been introduced personally by colleagues of mine, Eleonora, and after 2 years, we had the chance to set up a meeting to discuss and to have an overview for not only rhinologists, for those who don't know, Professor Prevedello and his colleagues, the team from the Ohio State, had a very large knowledge of the skull base anatomy. They're performing a lot of neurosurgical approaches. So I've been asking to him to have a presentation and in a short presentation of 25-30 minutes. If we will go more into that, we will probably have more appearance and more presentation by him in the future. But for now, let's stick to what's his presentation on the skull base and the rhinologic anatomy for rhinologists. So if you would please share the presentation. I remind all the attendees, if you have any questions, please type and we will go and reply to those questions at the end of this presentation. Professor Prevedello, the torch to you.
Yeah, thank you so much. We are really an honor to be with you guys today. And like was said, please ask any question, if you, anything you, do you see my slides okay, right? If you have any question, you can interrupt me and we'll be happy to go over. You know what, I'm gonna show some of these dissections are really the work of a lot of the fellows that spend time in our lab and really coming from all over the world. So I don't have the list of all the names here, but I really thank all the fellows over the years. So I'm gonna show some of the way we think about the anatomy, and like Puya was saying, we're happy to come back and go in more detail. So here today, I'm gonna start going through the way we think about the anatomy. So we came from the vestibular area, of course, and when you look at the first part that we encounter, really the turbinates, right? The superior, medium, and inferior turbinates. Do you see my arrow? You do see my arrow there, right? Yeah, so that's good. And then if you think about as you go deeper, and I like this initial view, the side view is not the anatomical surgical view, but it's really good to understand the relationship of the entry point here for the sphenoid, where you have your pituitary gland, the pituitary stalk going there, and the clival per se here all the way down. And then you have the choana, where it gives you access to the lower part of the clival. So if you look at here, the superior turbinate has a relationship with the anterior skull base. The middle turbinate gives you like a direction to the sphenoid, and the inferior turbinate points down to choana here. So all those are relevant aspects. And then behind the clivus, you have here these very important venous plexus, which is the basilar plexus, that you have to go through and control if you're doing approaches to posterior fossa. And you have access to this very rich area of anatomy here. If you go through the pituitary gland, we call the pituitary transposition, and remove the dorsum sellae, give you access to the interpeduncular fossa right there. And that has a relationship with the mesencephalon. So all those areas you could access, coming directly there. Through the dorsum, below the dorsum, you can go through the basilar plexus. It will take you to the prepontine area where the basilar artery is there, and it has a relationship with the pons. And inferiorly here, when you go through choana, inferior turbinate choana, and you can actually go through the foramen magnum and have access to the premedullary cistern where the vertebral arteries are there. So we're going to look a little bit of the details, what is relevant. When we look from the front, and I'm going deep in the skull base, we're going to go back a little bit. I'm just showing the importance of understanding where you're going, right? So with this view, you see all the places we can go with the endonasal. The pituitary gland, which is the first works that happen in surgery more than 100 years ago, through the nose and through the ethmoidal sinus, just to go to the pituitary gland is the center of all these areas where you can go. So you can go below the gland and you can go here to the premedullary, the intermedullary, premedullary, prepontine, and interpeduncular fossa. All these through a transclival approach. You have access, you see the basilar artery, you see the vertebral arteries. You know, the 6 cranial nerves are basically your lateral limits for these approaches. Superiorly here, you can actually transpose the gland. You can go to interpeduncular fossa. You can work near the 3rd cranial nerves there. But if you look here, how much space the carotid artery really takes, and we have to really learn the position of the carotid arteries and the relationship with all the other anatomy. So this is what we call the paraclival carotid artery, goes up. Then you have the siphon, where it forms the intercavernous or intracavernous carotid artery, the siphon here, the paraclinoid, and then you can see the ophthalmic artery taking off right there under the optic nerve that goes to the orbit. This is the annule of Zinn right here in this corner, and you see the muscles taking off there, going to the orbit. See in this side here, the superior orbital fissure was dissected. You see the lamina papyracea still covering up, optic nerve and ophthalmic artery. This piece of bone here is the optic strut that you see a lot of denomatization that is forming the optic carotid recess. But this is, I'm not gonna go in much detail more here, but it's really just to see you can go to anterior fossa, you can go to posterior fossa, you can go to middle fossa with an endonasal approach coming ventrally. And that's the main idea to show here, and also the orbits, as I mentioned. So very important to talk about anatomy. And I think this is why we're here. This is why, Dr. Dehgani-Mobaraki put this for us today to really emphasize, right, that you have to go to the lab, you have to dissect. You know, it's very interesting. Right now here, I'm not in Columbus, Ohio. I actually drove to Pittsburgh, and I was actually with scrubs dissecting with the residents of Allegheny Hospital here in Pittsburgh. And we had a session, we did endonasal dissection, and I had, oh, I'm sorry, I have to go now teach to Italy here because that's what we are. But that shows the importance, right? Like we are spending time in the lab, we're spending time talking about anatomy because that's what really matters. So we can go to the lab, after the lab, and you can go to a patient and you're gonna find the same things. You're gonna do a good job if you know anatomy, and you gotta be familiar, you gotta expose the carotid artery, you gotta find your basilar artery, expose the pituitary gland, and then in this case here, we remove a meningioma that was located in the posterior fossa there. So let's focus more on the superior corridor, how we do that. And to know that we need to understand the bone. I like to start with bony anatomy and X-ray anatomy, like a CT like that, to understand what you're doing. So historically, the ENTs were afraid of the sphenoid sinus. And the neurosurgeons knew only sphenoid sinus, but because they will put the speculum there, go into the sphenoid sinus and go to the pituitary gland. That's 20 years ago. And the teaching in rhinology and FAST is like, you're gonna be great if you don't go to the sphenoid. You know, don't go to the sphenoid, then you're fine. So I think over the years, ENTs and neurosurgeons learn from each other, and now we're all familiar with the sphenoid sinus and able to do surgery there. So why I'm saying that? Because the lateral wall of the sphenoid sinus, if you look at right here, is the medial wall of the superior orbital fissure. And this is something that you have to have in mind. And I remember a case that happened back in the day, I'm not gonna say names, that the surgeon put a speculum through the nose, crack it, open more speculum without dissecting properly the anatomy. That was the way the neurosurgeons were doing surgery. And he cracked it, took the pituitary tumor out, and the patient woke up with frozen eyes, bilateral frozen eyes, no movement. And that was why, because it cracked this sphenoid lateral wall and it squeezed the superior orbital fissure on both sides. So we don't do that. You gotta respect the lateral wall of the sphenoid. And that's very important. So now is an internal view here of the sphenoid bone. You see the plano sphenoidale, you see where the optic nerve comes through. You have the tuberculum celli there, right there, and then here's the dorsum celli with a back view. And you can see here the superior orbital fissure, you know, laterally, and the optic strut really comes as the floor of the optic canal. inserting here on the anterior clinoid. And those are one of the landmarks, like very important when we're going to the anterior skull base. When we're navigating to the lateral skull base, then you have to think about foramen ovale and foramen rotundum. So this is foramen rotundum right there where V2 is going to go through, and you see foramen ovale right here as part of the bone. And those are very important structures that we need to understand. When we are coming through the nose, we have to add more bones, and also we put the vomer there in front of the rostrum, the sphenoid, and then you have the shape of choana that starts forming right here that we have to be familiar. Then you add the ethmoidal cells here with the ethmoidal bone, with the vertical lamella, and then it start getting more complex to navigate. And that's why we're gonna go over now when you put the endoscope, what do you see? So here in this right side nostril of this specimen, you see the septum here, and you see the turbinate, inferior turbinate touching the ground. So you can always like retract and medialize this a little bit, and then lateralize, get a nice corridor through the choana. Up here, you see the middle turbinate. You put your endoscope all the way to the back, and you will see the soft palate down here, and fossa Rosen-Miller back there. This is the nasopharynx. And you see torus tubarius in the back. So you can do that first inspection, then you take back, and then the question is what to do the middle turbinate. And that depends, like if we are doing an expanded approach and we're really going through plano-sphenoidale, going intracranial, we need more space. And that's when we don't hesitate, we take the turbinate. If we have a patient with a lot of space and you're just approaching the pituitary gland, you don't necessarily need to remove the turbinate. You can preserve, you can lateralize, and bypass and go back. So once you make your decision with the turbinate, then you have to start thinking about flaps, because we do a lot of expanded approaches, and we'll be happy to come back and show surgeries. The idea today is to really emphasize the anatomy as a step-by-step process here. So you see the choana here on the right side, you see the roof of choana, and you see the os of the sphenoid up there. And from the os to the roof of choana, this is what we call the pedicle of the nasoseptal flap. This is the structure that when I started on skull-base endonasal surgery, a lot of the ENTs, they didn't have this concept of the flap, and they were afraid of having a epistaxis. You're gonna have epistaxis, so you have to burn. So they were burning all these here to get access to the cella. That's what we don't do anymore, because this is a very sacred tissue. Because if you want to use a nasoseptal flap, you don't want to burn this tissue from the os of the sphenoid down to the roof of choana. So we put an incision down here, which is the lower incision of the septal flap, coming curved in the superior aspect of choana and coming into the septum. And then we follow that anteriorly in the floor of the nose all the way anteriorly. And in the upper part, we go on the os here and we come anteriorly. You don't want to be too high to avoid damaging smell. You want to go just below the smell fibers and then extend that anteriorly. When I started with transsphenoidal surgery, it was very common to come to this area and just crack to the other side, because this part of the septum and the vomer, it's very thin bone. You can actually crack and go to the other side. And that's why the way we did the speculum surgery, we'll crack to the other side and it's open the speculum, and you have the entire face of the sphenoid open for you. We try to avoid that. We elevate flaps and preserve the mucosa nowadays. So this is the way it looks like once you get a flap done here on the right side. You would dissect now the mucosa of the other side, exposing the face of the sphenoid, the rostrum, and you can then drill down here, get a septostomy with a backbiter, and you can actually have access now from both nostrils. Then the question is what to do with the mucosa of the other side. What we've been doing when we do a flap on the right, we actually perform a cut in the back, and we use the mucosa of the left side to rotate and do what we call the reverse flap. And that's one of the ways some people keep this. I know that I think Dr. Aldostam in Brazil, he actually keeps this mucosa. He performed a vertical incision more anteriorly on the left side just to pass his instruments, and it will look like this. You have an incision there that you enter through the nostril on the left, goes through the incision, and then you parallel to the septum, you can actually get the same view, and he lateralized. I appreciate that he does that, and I think the He claims that the anatomy on the left side is all preserved, which is very nice. I do think if you're doing a planum sphenoidale, I feel that this is a little bit on the way. So I like to remove this tissue, rotate, do the reverse flap, and get this view of the sphenoid sinus. Here we're doing some backbiter of the septum, and then you can open the sphenoid sinus and get this type of visualization. And here's then we have now the anatomy of the sphenoid sinus, which is very important. Remember, I was talking about the optic strut. So the first thing you have to look here is the OCR, or the lateral optic recess, optic carotid recess, on right and on the left side. Clearly, you can see the carotid artery. This is an area where the carotid artery can be dehiscent. So you have to be very careful when you elevate mucosa from this area. You don't want to bite too deep, and this is a very vulnerable area for the carotid. It's not as well protected with very thick bone as the rest you see here. So very important to remember that. Septations, they tend to go to the carotid. We look at these, and when we look at several cadaver specimens, and I would say it was 88% of the septations in one point have some contact with the carotid canal, as you can see here, here and here. So we will drill this carefully and not to crack it too deep and have a problem with the carotid as well. So you always want to make sure that you're careful with the carotid. Be careful when you use drills that are cutter. I've seen a video, I'm not going to say names, but I've seen a video of a very experienced neurosurgeon, ENT, sorry, and he was drilling this lower part of the sphenoid sinus. And because the cutter drill bit has those indentations, it got to push one of the septations deep, and the septation cut the carotid artery. So you want a more smooth type of drill when you're doing this. I like an aggressive, but still diamond. So a diamond, a rough diamond type of thing. And those are very good to kind of drill out and get this smooth out. And then you have the sella behind you there. You have the tuberculum sellae above the pituitary gland area. And the tuberculum sellae laterally is where you have the optic canals. So those are important relationships that help when you're doing this type of surgery. Some patients will have a little different position of the carotids, as you see in different publications, but the relationship with the optic and the carotid is quite similar in everybody. The difference will be some of the pneumatization that may not be there. So sometimes you don't see this hole here, the lateral optic carotid recess may be completely full of bone and not pneumatized as this specimen you see here, but the relationship with the carotid and the optic is always there. And then we want to, depending on what you're going to do here, you will do an exposure. Very frequently, we expose these portions of the carotid artery as it enters into the anterior skull base through the dural ring in order to have a full control and exposure of the anterior skull base. Like I said, be very careful with those segments of the carotid artery. This is the most vulnerable area. Middle clinoid sits right here, and about 10 years ago, there was some confusion on the literature. What is the middle clinoid? And anterior clinoid is going to be on the lateral optic carotid recess. If you continue through this pneumatization, which is the optic strut, so meaning that above you have the optic canal, and below you have the superior orbital fissure just in front of the carotid here. So that will take to the anterior clinoid. Some people will have a ring basically around the siphon of the carotid artery that comes in this direction and calcifies with the middle clinoid. So when you're removing the middle clinoid for cavernous sinus exposure, it's very important you pay attention to these situation here, because if you try to just crack this, and if it's a full ring, imagine that the back part of that ring may come into the carotid artery. So you want to take a look at CTA carefully, make sure you're not dealing with a ring around the carotid there. This is the distal ring of the carotid artery, so we can expose all that. And here's an example looking from inside, where you see that anterior clinoid, it can form a ring with calcification in the direction of the middle clinoid right there. So remember, the tuberculum sellae stops right here. This is the upper part of the tuberculum sellae, but then the middle clinoid really goes around the clinoid and it can form a ring. It's usually around 4% of people can have a full ring. And that's a number just to remember. So it's rare. Most of the time is like you're seeing here, not a full complete ring. but it's a spiky process. So you can actually have a problem with the carotid artery if you don't pay attention. Optic nerve travels to the optic canal, and you can see under the optic canal, that's the optic strut that we were talking about. So imagine you're inside the sphenoid under this bone, and you look to the side, that's the hole you see with the optic on top and the carotid bending right here. So it's important to create a 360-degree view of all these, because that optic strut is basically the base of the anterior clinoid. The neurosurgeons are more used to see this view and drill the optic strut from here, disconnect the clinoid and rock it and take the clinoid out. We do that for historically for ophthalmic aneurysms and some anterior clinoid meningiomas. So we've been doing that for a long time. And then so when the neurosurgeons look from inside, they have difficulty to see that actually that hole in the lateral carotid recess is actually the pneumatization of that structure, the optic strut. So that's important, and you create this in your mind. Here's a picture of a very long middle clinoid that was removed from that area. And you can see here that if you're dealing with the cavernous sinus, dealing with the carotid artery, you really want to make sure that that this bone is removed, because it will give you much more freedom and around here, the medial aspect of the carotid artery. Sometimes pituitary adenomas that invade this area, we will be aggressive by taking all this bone, and that allows you to enter the medial wall of the cavernous sinus there and take tumor out. This is the full view. Like the other consideration to remember in terms of anatomy, see these dark areas here, those are the inferior intercavernous sinus. It connects the venous blood from the inside the cavernous sinus to the other side, the cavernous sinus. You have the superior intercavernous sinus there as well. So this is important because some tumors actually use those lakes to climb that way. It can be cancer, or it can be meningiomas of the cavernous sinus. They would actually travel. The most superficial layer of dura here is the periosteal layer, and the one deeper is the meningeal layer. The meningeal layer forms like a sac around the pituitary gland. And the periosteal layer, everywhere there is bone, there will be a periosteal layer. So in between the two layers is where you have these lakes of venous blood. So we take advantage of that, and we can do a transposition. We can do several things with that knowledge. In this picture here, we see we expose the carotid and we open all the way lateral to the pituitary gland, and we are dissecting between the medial wall of the cavernous sinus and the tunica of the pituitary gland. And that we can do a transposition with that. I'm more and more doing just what I call hemitransposition, where I disconnect one side and I swing the gland, and you do your surgery, put the gland back. The reason I do that is not to do on both sides, because when you do on both sides, you have the chance of disconnecting the venous drainage of the pituitary gland completely. And then you have a very blue gland at the end that may not be working so well. So that's when we will mobilize the gland. And here's another specimen showing this compartment where, just to emphasize, the periosteal layer in front of the pituitary gland comes down where there's bone, and the meningeal layer goes up right there. So they diverge where the venous blood can travel. And this is an opportunity you can actually enter to the periosteal layer and goes to this compartment called the medial compartment of the cavernous sinus. The only important structure there is the inferior hypophyseal artery that is traveling there. And that is, you have to be careful, but it is an opportunity here to remove tumors from this area that we can take advantage. If you see here the carotid traveling the siphon, this is the optic strut that we talked about. And now this is the distal ring of the carotid artery. And then the carotid artery goes intracranially, takes off here the ophthalmic, and this is the ophthalmic on the other side. So this is just some of the important anatomy. This is in a patient where we remove the plenum completely. And just to show you, you can combine a removal of the plenum sphenoidale with the opening of the optic canals. And you can open suprasellar where you see the arachnoid. And we often do that more. I do more than ever. I do aggressively for tuberculum cellae meningiomas, for instance. We open the canal medially here and there, and we have access to the optic nerves bilaterally, which is very difficult to do with a craniotomy, particularly if you're coming in an angle. So other important structures here, the superior hypophyseal artery. They're branches from the carotid cave, and they come even before the distal ring, and they take off immediately here in the suprasellar area, and they give blood supply to the chiasm and also to this cisternal segment of the optic nerve. You see the pituitary stalk back there, and those are important considerations when we are doing suprasellar work. Here you see the chiasm with the anterior cerebral arteries, with the frontal lobes. Those are all structures that we can expose coming endonasal. I was respecting the superior hypophyseal arteries, which are very important in order to preserve vision for these patients. Craniopharyngiomas have a tendency to push those arteries anteriorly, as you see in this picture, and meningiomas have a tendency to push those arteries posteriorly because they grow from the dura. And just to have in mind when you're doing craniopharyngioma surgery, because you can open the dura and you don't want to damage them right away. This is one picture here. You see them in a patient. So just to finalize here, we're going to go now to the anterior skull base, and I think this is very important for the ENT crowd out there. It's very important. We actually just did this in the lab this morning. Understand the anterior and posterior ethmoidal arteries and the relationship with the cribriform and also the posterior wall of the frontal sinus. So I'll show this here. You see that in this patient or cadaver, we had anterior and posterior ethmoidectomies done all the way up. So you see from lamina papyrica to lamina papyrica, an exposure of the anterior and posterior ethmoidal arteries. Posterior ethmoidal arteries, they tend to travel inside the bone. Very frequently, if you want to ligate them, we have to drill them a little bit, expose them, let them bleed, and then you bipolar and cut. And we will do that for esthesioneuroblastoma or sometimes for factory groove meningiomas where you want to reduce the blood supply. This is an anterior ethmoidal. You will bipolar and cut those bilaterally in those situations. This is the beautiful draft 3 when we connect the drill out of the beak here. The beak is this part, and we will connect the septations from one frontal sinus to the other. In this cadaver, we remove the mucosa, but often we will keep the mucosa on the frontal sinus because you want to keep the functionality of the frontal sinus. And then we will remove, let's say we want to do for aesthesia, we want to go all the way around this cribriform. We'll ligate the ethmoidal arteries, remove this bone, and then we remove crista galli, which is right in the center here. And you can drill around and you can actually cut all the way around this dura and remove this in block, particularly for cancer like esthesioneuroblastoma. When we remove this in block, then we need to go near the optic nerves here, and we will cut the optic tracts because of like esthesias, the disease comes from the olfactory nerves and tracts, and they can actually kind of travel through the nerve. So we will cut the nerve and send a specimen for margins. And the same thing we do for all the dura all the way around. We will get dura here, and even anterior around the cribriform to get margins all the way around to make sure you got a complete resection on esthesioneuroblastoma. So just a few more pictures here. When we're doing a transposition, we will elevate the dura and expose the dorsum celli. The dura of the back of the pituitary gland usually very adherent to the posterior gland. So I try not to separate. I try to elevate with the dura, because if you try to separate, you're going to see the posterior gland damaged. And you want to keep that dura there. These are the 2 layers of dura here that we talk about. Meningeal layer goes up and periosteal layer goes down around the bone. And these here in vivo will be bleeding venous. And this is very important to understand this, because if you bipolar this without understanding what you're doing, you may make this hole bigger. So nowadays we inject a little bit of a hemostatic agent to control the bleeding. You can bipolar, collapsing both layers, and then you can do that. These are what we call the pituitary ligaments, just some like a mesenchyma, some little attachments that you have from the tunic of the pituitary gland and the medial wall of the cavernous sinus. We keep that dura attached. As I showed you here, the posterior gland can be very attached. So it's better to roll with the dura up. Like I said, I've been doing this only one side, but when we were doing both sides, it will look like this, because then you have space to remove the posterior clinoids, the dorsum celli. You can open that dura. You can look up, and this is the stalk under the chiasm going to the gland. And once you open this dura here, then you see this. This is the interpeduncular fossa with the mabillary bodies there. You see basilar artery going up. And this is, in my opinion, the best approach to reach the interpeduncular fossa. The limits of this approach is the third nerve, as you can see here, and the third nerve is hidden behind this fetal posterior communicating artery there. So you can actually remove craniopharyngiomas, meningiomas, and difficult tumors from this region with a good visualization without the need from coming from the sides and manipulating all this anatomy here to reach structures that are located in the center. If you put your scope like more lateral, you see how many like vascular structures and perforators you'll be dealing if you come from the sides. So it's definitely the best view you can have of the mammillary bodies in terms of neurosurgical approaches. You can transpose the gland, as you can see here, and you can work from third nerve to third nerve in a good freedom of movement. If you put your scope laterally, you can see the fourth cranial nerve, you can see the fifth cranial nerve there, and the third cranial nerve going to the roof of the cavernous sinus here. And down there, you can actually see 7 and 8 going to the internal acoustic canal and the inferior cranial nerves inferiorly there. So, of course, it's not easy to work, but if you have an endoscope, you can actually visualize all that anatomy. So with that, I would like to thank Puya one more time for the invitation. We've been doing this course for a long time, and our next one is really in a week or so. Here we are opening again after a couple of years not doing this picture here. You can see it's from 2015, but our next one now is really from, we've been doing this for several years, and we're happy to open again for courses. And I think we're full now, but for those interested for next year, we'll be happy to get emails and put you on a list. Thank you so much, and I'll be happy to answer any question.
We had a loss of connection for a while. Yeah, got back.
Good.
So thank you for the presentation. Of course, there are some questions, but we are running out of time. So in case anyone is interested to have more information, is there any chance for you to reply to those messages? And the next most important information is that, do you have a plan for your upcoming dissection or cadaveric dissection course, which you would like to promote over here?
Yeah. So this will be just this 19, 20, and 21 of May. It's coming up. I believe this one is full and at this point, but I'll be happy to get emails for people that are interested coming next year. You know, this is filling up quickly, particularly now that we're 2 years without a course. I know people are really excited. If somebody really wants to come now and then in a week or so, send me an email. I can see if we can come up with another station there. Like I think we're already with 17, 18 stations already that filled up, but we can always accommodate if somebody wants to kind of come last moment. I'm sure it's going to be great. We're going to have a live demonstration surgery. We'll have some theory discussions, more like a round tables discussion about cases, what to do endonasal, do open, what's the best. And then we will proceed with a lot of 3 days of dissection. And so it will be, I think it'll be great. And Puya, I'll be happy to go over. I think I have more anatomy to show. If you are interested in another 30 minutes in the near future, we can go transpterygoid, carotids, and go lateral. And I thought that this would be the ideal for 30 minutes, what we showed in the last half an hour.
Perfect. It's going to be the next appointment for the next season. A few minutes for few questions that we have.
Yes, absolutely. Yeah. I haven't, I don't find the question. So if you could.
No. I have it because it's they're coming from the different platforms, YouTube, Facebook, Twitch. It's interesting how Twitch is now now very, very frequent. It's more for games, but also people joining from that. The first question is coming from Brazil. What is the distal ring?
So the distal ring is the dura band around the carotid artery, where the carotid transition from extracranial to intracranial. It basically is a tight ring, right? Anel dural, I'll answer in Portuguese. Anel dural que prende a carótida enquanto a carótida está indo do extradural para intradural. Posso dire in italiano, va bene.
I love that. I love that.
Yeah.
So the next question is that from Spain, when you perform a transpterygoid approach, is it important to leave the Vidian canal if it's already invaded by a tumor?
So no, so if it is invaded by a tumor, usually the way I do, I cut the Vidian and remove all the tumor that is more superficial. And then you end up with the tumor just in the Vidian nerve. And then I follow drilling that all the way to the carotid artery. I take a piece and I send that to pathology and I say, is there still tumor here? And then they say, yeah, there's still tumor. And then we keep going. And then until you get to the point where you skeletonize the carotid and you have the Vidian, and then it's questionable. Like usually, let's say it's adenocystic carcinoma and you're still getting tumor and you're basically taking pieces of nerve of the superior petrosal, the deep petrosal, deep superficial petrosal nerve there. And then you don't, that doesn't make sense. Then it means you're not going to be able to clear everything. But the beauty is that very frequently, as you get close to the carotid, you send a piece and they say, oh, it's free of tumor. There's no, margins are clear. And then you're fine.
Another question from Germany is that if you have an adenocystic carcinoma from the left nasal fossa, would you perform a bilateral ethmoidectomy?
It's of course case by case and how much is involving, but when we're dealing with cancer, we tend to be more aggressive. Like we would open more because I prefer to have a bilateral approach, to have two hands, one at each nostril, in order to drill well and not too tight around the Vidian nerve, for instance. And so we may not do transpterygoid on both sides. We may do transpterygoid on one side, but open of the sphenoid, we will do bilaterally, and removal of the septum to get a good space and visualization of the structures.
Question from Greece. Best flaps for reconstruction of Mackelscape? That's...
yeah, well, Mackelscape is more lateral. And what happens is, you need to have a flap from the other side in general. Like there are exceptions depending on the tumor, but if you're doing, let's say a trigeminal schwannoma of Mackelscape, I prefer to have a flap on the other side and do a transpterygoid more aggressively to get a full visualization of that corner. So we will remove some of that, lateralize the pterygopalatine fossa. You might ligate the branches of the palatine, the sphenopalatine artery. So you don't want to have a flap there because you want to really lateralize this. So really what we use is a nasoseptal flap from the other side. That's our typical for Mackelscape reconstruction.
Another question from Italy. Best option for septal perforation?
Well, I'm a neurosurgeon, right? So I don't do a lot of septal perforation, like a reconstruction. So I don't know if I should be the right person to answer that. But I'll tell you, like in general, what we try to do in a normal person is to create this septostomy more posterior. So anteriorly, there's no septal perforation at all. If the person is on cocaine with a perforation and has problems with that, then I'm not the one that takes care of that. I think my partners, rhinologists, that they do septoplasty and things like that.
Last question is from Portugal. What's your opinion in decompressing the whole I don't get exactly this question. Like, I think that it's going to be the way to make orbital decompression or optic nerve decompression?
Well, we do that quite a lot through the nose. So I don't know if I understood the question, but we can do that unilateral. Sometimes if you're just focusing one side, we don't need to open the other side. We can do a purely left side, for instance, ethmoidectomies. Then I get to lamina papyricia, remove lamina papyricia, get to expose the periorbit. Then we go all the way posterior, see the takeoff of the optic nerve. We drill the medial wall of the optic canal, crack that, and then we can have periosteum all the way to the anterior skull base. And that's an extradural decompression. Sometimes for tumor invasion inside the optic canal, I would open the dura and actually cut the periosteum to really open more and give more space for the optic canal, optic nerve.
Now he formulated the best way. The question is where you would make the incision in which portion of for the decompression, in an upper position or lower position. I think that is related with the position of the internal carotid artery and the.
So for the orbital decompression, it's like, say somebody has a proptosis and you want to just cut the periosteum. So we usually don't, we usually go posteriorly and somewhat inferiorly. We angle the knife in a way that you don't go too deep. And then we come from posterior to anterior, we cut that periosteum, like opening so the fat comes into the sinonasal cavity. And usually we do two cuts, like one from posterior to anterior, like it's still anterior to the optic canal. And he asked anterior or inferior or superior. We actually do them both. You just got to be careful as you go superior not to get too close to the trochlea, to get the insertion there to cause double vision. But if you just stay very superficial, just cut the periosteum, and then you keep a band so the fat doesn't come too much. So you have one open above, one open below. That usually is enough.
Very, very last question from Poland. I would like to make some suggestion for the resident with this last question. And he's asking, would you pack the nose if you perform an orbital decompression?
We usually don't. We don't put anything special. We just let the fat there. It forms mucosa on top of it very fast. What I see, I'm not an ENT, but my ENT partners, they irrigate, they take care of the nose. They see these patients a few times after the procedure. But what I see that happens very quickly is the granulation and formation of mucosa on top of that fat. And I initially in my career was worried about infection inside the orbit. I've never seen. The fat goes there and I think it's so vascularized and mucosa forms. I never had any problem with infection.
Perfect. Thank you for all these replies, and I really would appreciate your participation for the upcoming semester. We can set up like a kind of 2-3 meetings for dedicated for anatomy and dissections. Thank you so much, Professor Prevedello, for being with us. I will remind all the attendees for the upcoming meeting, May 11, with Leila Madi from the US. She will talk about anatomic consideration of microvascular free tissue transfer in endoscopic endonasal skull-base surgery. Thank you for the participation. And for anyone interested, you can watch again this meeting on our YouTube channel. Thank you, Daniel, for being with us. Grazie ancora.
Grazie tanto, va bene.
Ci vediamo in Italia o probabilmente in the US.
Ci vediamo la prossima volta. Un piacere, grazie tanto.
Piacere.